The equipment is very clever. It has multiple functionalities built into one device. The equipment can do a whole eye wavefront measurement. It can measure your axial length. It can measure your tomography. And so it then puts it all together to design a treatment for you. It is all automated. One has to set up the room carefully and meticulously and has to set up the patient correctly. The equipment needs a reasonably darkened room, but not too dark. It needs to be darkened enough so that the pupil is dilated enough so that you can capture enough wavefront data of the whole eye. If you get it too dark sometimes, the patients start accommodating and their refraction changes. So there has to be some amount of light. If you have a light meter, you can put it next to the patient's face and roughly 2 to 3 lux will get you there. It's roughly opening the one door halfway and letting the outside light come in a little bit. Then the second step is to get them seated correctly at the sitemap device and look past the balloon target. And we encourage this of the patient is to not just look at the hot air balloon, but pretend you're looking past it. That will relax the accommodation. The third trick is, if you roughly know where the script ought to be, you take off the autofogging and you go a fraction past it and then manually pull the refraction back, the fogging back towards where it ought to be. And often if you do that, it now becomes normal practice, normal routine for you.
So when they look into the sitemap, they will see a hot air balloon. At the beginning, we had the patients focus on the hot air balloon, and naturally, as soon as the patients see the hot air balloon, they do want to focus directly to it. This actually means that they then accommodate and we don't get accurate results. So prior to them sitting down on the machine, I normally let them know that they will see the hot air balloon, but we actually want them to focus beyond it to the very end of the road. We want them to have their eyes relaxed and pretend they're looking at something really far away in the distance, something far off in the horizon. I find then when they sit on the machine that this then helps, that they then look beyond the hot air balloon. We can even advise them that the hot air balloon should be blurred because they should be looking at the very end of the road.
Tips to correct overcorrection. The errors can happen generally, and this is not just Wavelight plus my own experience as a surgeon, can happen if a patient's script is incorrect to start with. And general advice is to get the correct cycloplegic refraction. And it has to be a proper cycloplegic refraction. If you use tropicamide or midracil to dilate the patient, you do not relax accommodation enough. So the correct medication has to be used, like cyclopentolate, to relax accommodation. The only other time we found an overcorrection was in astigmatic correction. We found an overcorrection of about 12%, 12 to 14%. Initially, it was unclear whether it was a result of entering too much script in it, whether it was measurement issue or not, we were not sure. Because oftentimes patients aren't wearing the full astigmatic correction that they need to wear. We find that that cohort, firstly, will over a few months improve. Although they'll be a bit blurry on day one, they will improve over the weeks. So we wouldn't rush into treating them at a month. We would wait a full 3-month period. And often we found there was about a 14 to 16% overcorrection.